We're here from Taiwan for the start of the third day conference.
Несиндромальных craniosynostosis.
And as you can see, they're speaking Russian. We have Simon, Slavin, and Marco on the panel. And we have a few good presentations. We have 4 presentations today, including Louis Borba, world-renowned skull-based neurosurgeon. There's a couple different talks. They're kind of going freeform.
Thank you very much for
here we're starting.
Neurosurgery of Tumen, especially Professor Sufyanov and Professor Barber for the invitation. Today I will talk of treatment and a little bit different. I will talk about the treatment of syndromic and non-syndromic craniosynostosis. I have been doing this for at least 25 years. And we can see here a draw of the variation of the skull of human beings. It's 21 different shapes of skull, but they are normal skull. And you have some culturally produced craniosynostosis deformity of the skull. You have this in Syria, in South America, and in Toulouse, France in 18th century. And maybe this is the reason that they are the fathers of the treatment of craniosynostosis. The classification, we have non-syndromic, it's according to the final format of the skull. And syndromic, then you have 2 types, craniofacial stenosis and acrocephalosyndactylias. The first classification that I found in the literature was the Fairman classification. And we have, at this time, 3 different types of craniosynostosis: scaphocephaly, brachycephaly, and oxycephaly. And oxycephaly was considered a complete craniosynostosis and compensated, and as compensated, it was about the presence of increased ICP. It's interesting to note that Crouzon's disease, and first described in 1929, wasn't clear enough to be considered a craniostenosis at that time, in 48. This article of 1997 in England of Dr. Thomas shows that we don't actually classify all the craniosynostosis, because the craniosynostosis is defined by the shape of the head and depends of which or how many sutures are closed, we have a different shape of the head. Unclassifiable craniosynostosis are rare, but represent less than 5% of non-syndromic case of craniosynostosis. In Toronto series, the unclassified multiple suture synostosis account for 7.6% of the cases. The non-syndromic, basically we classify in scaphocephaly, trigonocephaly, plagiocephaly, frontal, brachycephaly, oxycephaly, and triphylocephaly. Scaphocephaly is the closure of the sagittal suture. The metopic closure will produce trigonocephaly. Unilateral coronal closure will be the frontal plagiocephaly, and posterior plagiocephaly will be the closure of the lambdoid sutures in only one side. Non-syndromic compound, we have variable, basically 2 sutures, brachycephaly, the bilateral lambdoid closure, and brachycephaly, that's the coronal bilateral closure. Virchow postulated the kind of deformity should be, but in fact we have the growing of the brain under the bone plates of the skull, and we have a different kind of deformity like this. Then you have these different shapes of heads, and you must correct not only the skull, but the frontal and posterior part of the skull base and the face. The goal of the surgery, early surgery, and nowadays we have a discussion what means early surgery. Early surgery until some years ago, 20 years ago, was about 30 to 6 months. Now, the ideal time for correction of craniosynostosis without a very high increase of ICP is about 6 months to 1 year of age, because you have less risk of need of a reoperation. So you need to do brain decompression and craniofacial remodeling. The first work is from Professor Lanelong in 1891, and he was the first one to describe the surgical treatment of craniosynostosis, linear craniectomies. In the 70s, Professor Tessier in France established the technique of craniofacial remodeling. In 77, neurochirurgy, we have the discussion of all craniofacial synostosis. It's a very good book of this neurosurgery supplement discussing the treatment, surgical treatment, but I think that the best book is from John Persing and John Daniel of Charlottesville, Virginia, treating about surgery of craniosynostosis. The linear craniectomies was postulated first by Lanelong and Lane, and total craniectomies started in 65 with Oyartovsky, and the craniofacial surgery, as we know nowadays, by Tessier in 71. This is a linear craniectomy postulated by Anderson and Geiger, and you can see that you did removal of the bones in the place of the suture, but we had, in this case, a premature closure of the bone and need another surgery, maybe second and third and a fourth surgery. The surgical treatment, we have many different techniques. Frontal orbital unilateral remodeling, Hoffman's technique, frontal orbital bilateral remodeling, Tessier technique, Marchak technique, craniofacial advance, Tessier technique isolated, and Ortiz Monasterio in monoblock. Usually, I use one of these three techniques: frontal orbital remodeling, frontal remodeling and orbital advance, and total cranial remodeling. This article in Journal of Neurosurgery in 2010 shows that patients with non-syndromic multiple suture craniosynostosis, you can do the treatment with endoscopic technique. First, you have one problem. The multiple sutures craniosynostosis, they have more risk to the need of a new surgery. And you can see the draw of this article was the front page of Journal of Neurosurgery. You cannot correct the facial anomalies basically in the size of the orbit. Maybe this will be a good technique for avoid a great loss of blood and to treat premature closure of the sagittal suture. In 2005-2006 was published an article of our group about the early surgical treatment of non-syndromic craniosynostosis. At that time, we did a surgery in a very young child with low weight, and we lost 2 patients because the anesthesiologist was unable, and the surgeon, both were unable to handle the blood loss. So at that time, we started to do the surgery with at least 6 months. We have now 246 cases, and you have scaphocephaly, plagiocephaly, trigonocephaly, and brachycephaly. Oxycephaly is not very frequent, and multiple sutures about 1.5–2%. And it's the same as in the literature. Scaphocephaly depends on the group, it's 40–60%, plagiocephaly 20–30%, and multiple sutures about 4%. So we have less than this. This is a case of multiple sutures. You can see a bizarre form of the skull in this child. The CAT scan showing the deformity, the closure of the lambdoid and sagittal suture. And we do a completely cranial remodeling. You remove all the frontal, parietal, temporal, and occipital bones. You do a fracture like a green wood in the base of the cranium, in the temporal area, and put the bone together with nylon. I knew that Intumen use Vicryl, and I think that's more smarter than us because it's reabsorptible, it's the same material of the absorptible plates that are very expensive, and our public health system, they don't pay. And this is during the surgery, after put the bone again in place, and the final results some months, 1 year after the surgery. Bilateral coronal lambdoid, you have a very, very narrowing of the anterior posterior diameter of the skull. As you can see, looks like a syndromic craniosynostosis, but it's not. And this child was about 3 months. You can see in the X-ray signs of increased ICP. The CAT scan, a bizarre form of the skull. 3D reconstruction and the bone flap during the surgery. This is another picture of during the surgery, and you can see the part without bone. It was so thin that like paper, the bone. They had a very high increase in ICP. And in the final, in the end of the surgery, you rotate the gallia and the temporal muscle over the bone flap to keep them vascularized, to avoid reabsorption of the bone. And you can see this patient 6 months after the surgery. The frontal orbital remodeling, as you can see in the plagiocephaly, in this case, we use nylon, we do the fracture, and we must advance only the left orbit. The right is in the right position, but you need remodeling both of them to keep them very well regular. And sometimes, if you have one orbit lower than the other, you need to put a little piece of bone under the orbit to keep an alignment. And this is another one with the plagiocephaly. What we can do with the surgery. This is a girl about 20-something years old, and the final result is quite good after many years. This article is interesting of Journal of Neurosurgery in 2016 and shows that we have an increase of craniosynostosis in the group of Hispanic patients and Black patients in the United States, but maybe they are poor patients, they don't have access to surgery, and usually they are treated, you have a delay of the treatment in these patients. Another subject that is very, very, very controversial is the use of helmet in patients with craniosynostosis. And this is from Wayne State University. I spent my research fellow there, but I do not agree. They use this helmet in patients with the sagittal craniostenosis, and they say that they don't have important increase in ICP using the helmet. But some of these patients, they need to do surgery, of course. And I don't think that's a good strategy of treatment. Another article that's very important of 2015 of the Journal of Neurosurgery Pediatrics is long-term developmental follow-up of the children with craniosynostosis non-syndromic. And they have a decrease in IQ of these patients, especially the verbal IQ, and they don't know why. They may be by the craniosynostosis, maybe by the time of the surgery, the anesthesia, or maybe for the increase of ICP. It's not clear, but these patients, even in non-syndromic craniosynostosis, they have a decrease in IQ. The craniofacial syndromic craniosynostosis is a more challenging disease. Usually we have Appert, Crouzon, and Pfeiffer. And Klebel-Schladel, it's a triphylicephaly, and Carpenter is more difficult, and Jackson and Lebixler are very rare. And craniofrontonasal dysplasia, you can see some of case, but basically Appert, Crouzon, and Pfeiffer. Another maybe considered nowadays syndromic craniosynostosis is the closure of the both lambdoid and sagittal synostosis. It was classified in 2009, and they call now Mercedes-Benz syndrome, because it looks like the star of the Mercedes-Benz. And you can see the posterior fossa had an inadequate angle in the occipital bone, making the surgery very, very difficult, and these patients they have Chiari malformation too. This is one of the 2 cases in 25 years that we have. And the final result, this patient, I don't have the MRI here, but he has a Chiari type 2 with no symptoms. For this reason, we didn't treat surgically the Chiari malformation. Radical one-stage correction of craniofacial anomalies was done by Fred Epstein in the 70s. And this kind of monoblock or N-block advanced is risky because you can distract the optical nerve, and this patient can have a decrease of the vision or even blindness. And nowadays you do a Lefort fracture, and advanced we use now plates in small child absorbable plates. In older patients in Appert and Crouzon, when correct and older, we use non-absorbable plates. And this is, you may have in a family, the mother has Crouzon's disease and the son has Crouzon's disease. This is another case of a Crouzon disease, the father and the child. And you can see that you use distractors with screws distractors. Some neurosurgeons use coils. I don't have experience with coils to treat craniosynostosis, but the distraction with screws, it's very useful, and you advance slowly and avoid blindness in these patients. These patients, they have a very high difficulty to breathe because the middle part of the face does not grow, and you have extreme situations like this patient with Apper's disease. You have syndactylia, and the correction is the same as we do in Crouzon's disease. In very extreme case, we have nothing to offer, and most of these patients get blind before have time to do the surgery. Sometimes when this patient has hydrocephalus, this case is a Crouzon's disease, where you can see the screw, and this patient, the surgery was done outside our institution. But we have another problem. Chronic tonsillar herniation in Crouzon and Appert syndrome. So these patients, they have hydrocephalus. non-communicating hydrocephalus. And we have syringomyelia too. And this situation was come to attention to Coleman in 2005, but it's not only in syndromics. In non-syndromics, you may have hydrocephalus too. In this case, you can see the Chiari type 2, you don't have the fourth ventricle, and it was necessary to put a shunt. What is better? In this syndromic case, it's better to treat the hydrocephalus a posterior decompression in early stage, because it doesn't bleed too much. Second, you can wait until 6 to 8 years old to do the treatment of the anterior part, and you can advance the face, because if you do the advance before 6 to 8 years old, you don't have a good results. And you can see this patient, the treatment was first wrong in another institution, and we had to do the surgery, put the shunt in this patient, and you have the complications, of course. If you don't treat early these patients, they will lose the orbit, they have risk of CSF leak, reabsorption of the bone, infection, and bleeding. Sometimes if you don't be very careful, the bone plates won't be, they will get fixed in the wrong position. What we can conclude after this speech? Correct diagnosis and timely of the surgical treatment allows the best aesthetic and functional results. And multidisciplinary approach improve the final result. I have no doubt, I'm about 25 years old, 25 years working with a craniofacial surgeon, and the result is very, very good. Once again, I would like to invite all of you to the Brazilian Congress of Neurosurgery that will be in Brazil, in Porto Alegre. Thank you very much.
Okay, we have a minute of commentary here. We also had the same topic covered in the Indian conference.
Mm-hmm.
But I'll tell you, we have great news. Yeah, we have great news. Roberto Herrera, noted Argentinian neurosurgeon, just called me on a Facebook call to set up something with Pakistan. He says, how do you do it? Skype?
Great.
I said, no, Hangout. And I think Albert, the host neurosurgeon, wants to start a channel from this center in Russia and Tayuman, possibly.
That's good news.
Yeah, hopefully we'll get to speak with Ipe too here. We're having a little problem communicating with the people, the host people, but we do appreciate the feed they're doing.
Mm-hmm. We got Slavin with us.
Yeah, Slavin. He's hard to get a hold of. It's like pinning the tail.
Hello, I'm really glad to be at this conference. I think it's really amazing to see such international representatives. That's one thing.
We have to go back to the conference.
Very good experience.
They frequently speak in Russian. Which of course I don't understand. I'm going to put this on Facebook Live if you guys want to watch it.
Slavin, can you understand Russian?
Well, a bit, but quite different from Croatian.
Yeah.
Okay, there's the tech. Victor has helped put this together. Now, I don't know if you guys realize the sound is excellent and the video quality is excellent. And he did that on one computer, which normally, as far as what I know, it takes 2 or 3 computers. But he did it on one.
Any word from our sponsors?
We're still waiting to hear. We're still negotiating.
Coke. It's the right choice.
Coca-Cola and Smirnoff vodka.
Remember, when you want a snack, Snickers is for you.
All right.
Okay, this is one of the Japanese presenter. Okay.
My topic this lecture is how to treat cavernous aneurysm. Okay. Okay, this is cavernous giant aneurysm cases. Do you think this aneurysm is treated too difficult or not? Okay. Well, this is IC 2 days before cases. Very, very, very difficult. Also, this is yesterday's MCA thrombus giant cases. Also, okay, like this aneurysm, much difficult because we must approach directly to aneurysm. Okay, but cavernous aneurysm, no need to approach directly to aneurysm. Okay, the answer is very simple. Okay, high flow bypass. Okay, EC arterial saphenous vein, M2 graft bypass, along with just cervical IC occlusion. Okay, we can treat cavernous giant like this approach. Recently, pipeline or stent device is useful, but not all cases. Okay, but we can treat surgically high flow bypass along with IC cervical ligation. Okay, if we can perform high flow bypass, this treat of this cavernous aneurysm not so difficult. Okay. Okay, these are 73 cases, high flow bypass and IC ligation. Okay, aneurysm gradually thrombosed and disappeared. This is 2 years girls. Left side of cavernous giant. Okay. Also, we can treat high flow bypass and IC ligation. This case is also okay. Usual aneurysms, if the size became bigger, the surgical risk is also became much more. Okay, surgical risk increased. Okay, if the aneurysm size is big. Okay, but cavernous aneurysm don't approach directly. Okay, only high flow and IC occlusion. Okay, so size is not so surgical risk. Okay, so surgical indication is only symptomatic cases. Okay, usually present with eye problem, diplopia, ptosis, sometimes facial pain because of fifth nerve compression. Okay, so small size asymptomatic cases, no need to treat, just enough conservative. Okay, but if the patient symptom occurs, okay, we must perform surgery as soon as possible. Okay, before the symptom become irreversible. Okay, no symptom, small cases, no need to treat. Just observation is enough. Okay. Okay. For the high flow bypass, there are 2 policies. Okay, one is a selective approach. It means perform in only selective case according to the balloon occlusion test. The other is a universal approach. Okay, it means perform all cases if ICA sacrifices. Okay, I take a position universal approach. Okay, because balloon occlusion test is not reliable. Sometimes fail. Okay, false negative case. Also, there is a possibility of the formation of the de novo aneurysm because of the hemodynamic stories, especially in young patient. Okay, so I recommend universal approach. This is the preparation. Okay, surgical field, head, neck, and forearms. Okay, usually I harvest affected side because draping is more easy. Okay, but we must confirm the collateral pathway of the forearm before surgery. Okay, using 3D CT, DHA, or RN test. Do you know RN test? Okay, we must confirm collateral pathway. Okay, if the collateral pathway is not good, poor collateral, we must harvest opposite side or saphenous vein. Okay, it's important. Okay, also for the safely surgery. Okay, most complicated risk of this surgery is occlusion of the graft. Okay, graft trouble is the most major complication. Okay, so we select the submandibular root. Okay, this part is blind. Okay, so the kinking or twisting of the graft of this part is a major problem. Okay, so we must take care of the graft root, how to create a good graft tunnels. Okay, this is how to create a graft tunnel. Okay, it's my techniques. Okay, from the cranial side, the root is the anterior part of underneath the diaphragmatic arch. Okay, just insert the Kelly clamps. Okay, no dissect. Okay, because of some bleeding, just insert. Okay, anterior part of underneath of the diaphragmatic arch. Okay, it's just lateral to lateral pterygoid muscle. Okay, just insert until here. Okay, from the cranial side. Okay, it's from the cervical side. The entrance of the graft is between digastric muscle and the hypoglossal nerve. This is the graft entrance. Okay, from the cervical side, okay, using a digit finger, okay, insert the finger and make a blunt dissection, not sharp dissection. Okay. The first medical mark is the steroid process. Okay, firstly you can touch steroid process, then create a wide field, then move to anterolateral. Okay, also we can touch pterygoid plate. Okay, this is the origin of the lateral pterygoid muscles. Okay, then move to laterally. Okay, like this. Okay, this is the root. Okay, first medical mark is steroid process, and touch pterygoid plate, and go to lateral, anterolaterally. But also this is just lateral pterygoid muscles. Okay, from cranial side, Kelly clamp come from here. Okay, so we can touch the tip of the Kelly clamp from the cranial side. Okay, like this. Then using a finger as a guide, just push Kelly clamp to the cranial cervical side, like this. Okay, then catch chest tube, 24 French chest tube, and catch. Then pull to the cranial side. So we can create a graft tunnel easily. Okay, this is a graft root. This is a temporal muscle. This is a radial graft. Okay, come. This is a lateral pterygoid muscle. Come. This is medial pterygoid muscle. This is masseter muscle, temporal muscle, lateral pterygoid muscle. And come. This is come to neck. Okay, this is how to create graft tunnel. Okay, also, I emphasize the good to useful techniques. Brain surface MCA pressure monitoring. Okay. I perform STA M4 bypass before high flow bypass. This so-called assist bypass. Okay, the purpose of STMC bypass is one is insurance bypass. Okay, because RA anastomosis M2. Okay, if M2 occlusion to lungs, is a risk of ischemic complication. Okay, so first we perform distal part of M2. Usually select M4. Okay, this bypass is more easy and less invasive. Okay, so if perform this bypass, M2 occlusion not so difficult, dangerous. It's all called insurance bypass. Okay, another purpose is to measure MCA pressures. Okay, this is a ST common trunk. One branch connect to anastomosis to M4, and another other branch connect to pressure transducers. Okay, so we can measure MCA pressure directly during surgery. Okay, this is a video. Okay. Sorry. Okay, this is a parietal branch. Okay, insert cannula. Okay, this is a parietal branch, anastomosis, and connect to pressure into the transducers. Okay, upper wave systemic blood pressure, MCA pressure. Okay, before opening graft, firstly block ICA. Okay, if the collateral flow is not good, MCA pressure decrease. Okay, it means no collateral. Okay, we can't block the ICA without graft. Okay, now open graft. Okay, now open graft. Okay, if the graft patency is good, this pressure increases gradually. Okay, like this. Okay, if you don't have ICG or Doppler, okay, we can confirm graft patency, these techniques. Okay, this is a finally occluded ICA. Okay. Okay, this is all steps of the graft surgeries. Sorry. Okay, surgical field, head, neck, or arms. Okay, after draping. If you have a two microscope and two surgical trims, start both sides is useful to shorten the operation time. Okay, but only one surgeon firstly start harvesting radial artery. This is the skin incision. Harvesting radial artery start distal part because this part running shallow layers, so easy to find. Okay, this is radial artery. Also, we use a so-called bipolar coagulation technique. Okay, they go into between two muscles, brachioradialis muscle, flexor carporadialis muscles. Okay. Firstly, dissect only superior wall of the graft from distal to proximal. Then, using a vascular tapes and give a slight tension and lift up. Then harvest all surrounding of the arteries. radial artery has many tiny muscle branches. Okay, coagulation and cut. Okay, please take care of avulsion injury. Okay, usually we need 20 centimeter for ECM to bypass. Then move to cranium. Okay, this is STA harvesting. Okay, these techniques also, we must take care of thermal damage of the arteries. Then common trunk, frontal branch, parietal branch. Then perform usual temporal craniotomy. But this surgery, we must take off middle fossa bone as much as possible. Okay, for graft root. Okay, then move to cervical dissection. This section is similar to carotid endarterectomy. Okay, this is a hypoglossal nerve, digastric muscle, ECA, ICA. Okay, for radial graft bypass, no need to expose common carotid. Only use external and internal carotid. Okay, this is a graft tunnel between digastric muscle, hypoglossal nerve. Okay, using a finger. Make a blunt dissection. Touch thread process, pterygoid plate. From the cranial side, just insert K clamp. Just lateral to lateral pterygoid muscle. Touch the tips of the K clamp and push to cervical. Here you can see the tip of the K clamp here. And catch a chest tubes. And draw from cervical to cranium. Okay, this is a graft tunnel. Okay, open dura, split children fissure. This is M2 for recipient for radial artery. This is recipient for STA. And first we perform STA M4 bypass. Okay, never take radial artery just before anastomosis. Okay, now take the radial artery. This is a so-called pressure distinction technique. Okay, inflate high pressure saline inside the graft. It's a useful technique to prevent vasospasm. Okay, vasospasm also the artery occlusion, the cause of the artery occlusion. Then tie up silk thread and graft. This silk inside the chest tube and pull from the cervical side. Okay, we can easily enroll the graft from cranium to cervical. Okay, then inflate the heparin to resolve kinking or twisting. Okay, this is very important procedure. Okay. M2 RA graft first. You can never start ECA RA. Then take off chest tubes. then perform ECA, RA, anastomosis. Okay, this anastomosis is no risk of cerebral ischemia. Okay, now perform MCA pressure monitoring. Okay, insert and connect to pressure introducer. In the block here, okay, we can measure MCA pressure directly. It's MCA pressure, upper wave systemic blood pressure. Okay, now block ICA. In this case, is no collateral. So MCA pressure decrease, no wave. Now open graft. Okay, MCA pressure gradually increase. Okay, usually come back 70 to 80% before occlusion. Okay, that's enough. That means graft patency is good. Also, ICG is useful for confirm graft patency. Then finally, ligate ICA. Okay. Okay, just finish. Okay, no need to touch aneurysm itself. Okay, only create a graft and ligation of cervical ICA. Also, no need trapping. Okay, someone recommend trapping. Okay, distal ICA, but usually only proximal is enough. Okay. Okay. Okay, my experience over 100. Get the graft patency around 98%, and complication rate 4%. Okay, this surgery is not so invasive, but not dangerous if you perform bypass safely. Okay, IC cavernous giant aneurysm can be treated safely by radial graft bypass along with cervical ICA ligation. Okay, no need trapping. Okay, brain surface pressure monitoring using STMCA bypass is a useful technique to confirm graft patency during surgery if you don't have ICG or Doppler. Okay, thank you for your attention.
Thank you very much, Professor. It's very interesting presentation. I know how are you tired, but you give this information our participants. Вопросы какие-то? Как там? Неужели нет? Вы устали? Все понятно по системе? Подождите, микрофон сейчас.
Professor, do you use heparin before performing vascular anastomosis?
Heparin? Only local, inside.
Only local?
No systemic.
No systemic.
No systemic.
See, in the future, hopefully we'll be able to ask questions like people on the panel from all parts of the world.
Okay.
Especially people that are interested in this topic. This shows the power of this platform. I mean, you could bring people from other parts of the world to interact with the speaker. Oh, here's this. Lewis is a superstar. You guys are gonna love this. He's an excellent speaker. You're gonna see. This is a treat. He's coming to Mexico. He's coming to Mexico to speak.
Okay.
Luis Borba from Brazil.
Okay.
опухоли краниоцервикального перехода.
He goes to a lot of conferences, neoplastic lesions.
It's tiring here after 3 days of working. I thank again the opportunity to be here, the opportunity to work with you and all the members here. I really enjoy the time here with the Intumin. Okay, let's talk a little bit about very short lecture, okay, about craniocervical junction. It's the place where I live. The craniocervical junction is defined by the bottom of C1 to the jugular foramen. This area here, you can have tumors, benign or more aggressive tumors, from the brainstem, from the medulla, from the dura, and from the bone, and from the nerves. You see, you can have lesions around of this area here. The most common then are the meningioma, chordoma, neurinoma, neurofibroma, some glial tumors, some hair tumors can have also in this area. For bone lesions like chordoma, the neuronavigation is very important because the neuronavigation show you. Neuronavigation will help you how to do the surgery. The endoscopy also is very good because you can see in the corner. In the microscope, you see only directly. With the endoscope, you can see in the corner. For chordomas especially, it's very important and very good to take the tumor is lateral to the view. The intraoperative monitoring also is helping a lot, especially for the cranial nerves. See, there you can be more aggressive in removal of the lesions. Okay, let's start with the chordomas. Chordomas is a tumor from the bone, okay, from the joint. Okay, synchronously. In this tumor here, it can come from the clivus, go up to the sella, go down to the craniocervical junction, and go lateral. See, it's located in the clivus here. And the main part of the tumor, the great majority of the time, is here, that junction between the occipital and the sphenoid bone. Arise from here and can go lateral or go superior. The chordoma is different than chondrosarcoma, is a midline tumor. Okay, for midline tumor, you need a midline approach. See, case like this, very simple. 11 years old, only dysphagia, a mass that's come out from the mouth. It's not very complex surgery, but the idea here is so easy to come through the mouth and do what we call the transversal approach. What's the trick of the transversal approach? Keep the midline. It's very important to keep the midline. How you found the midline? You found the two joint. See? One side here, another side here, you know that you are in the midline. Be careful that inferior to C2 here, the vertebral artery is exposed here. If you go lateral, you can damage the vertebral artery. But this is important to keep the midline. The neuronavigation will help you here, the anatomy will help you here also more than navigation. It's like do the cervical spine, anterior approach. So the two muscles in the middle, okay, you go just in the midline. See like this, just open the mouth, you can reach the tumor. Directly, it's the transoral approach for craniocervical junction. For lesion that is high, superior to the hard palate, it's better to come through the nose. Okay, then transoral. In the lesion go more lateral, it's better to go lateral. Anterior approach for midline lesions. A case like this, you see a large tumor here, but there is erosion of bilateral of the condyle. In this case, you need fixation. We do at the same time, we remove the tumor, you turn the patient, and do at the same time the craniocervical fixation. It's very important, okay, to keep the stability of the area. Go first, remove the tumor anterior, and come back and fix posteriorly. Sometimes the chordoma can go bilateral. Recurrence tumor go more lateral. In this case, you need to do the approach through the temporal bone or through the condyle, like extend transcondylar approach. You go inside the tumor, drill the tumor, drill the bone, and take the tumor out. The most difficult in chordoma is not to remove the tumor. You don't know when to stop to remove the bone. You never know when the bone will be totally free. Because of this, the neuronavigation is very good in this situation, can help you. If you start to continue drilling, you find bone islands, isolate islands, away from the main mass. And the pre and post-op is the route that you use, in this case, to reach the craniocervical junction. Okay, the most important tumor here in this area is the foramen magnum meningioma. There's a lot of controversy here that you need a kind of approach to transcondylar, extremely lateral. It's very confused. Have more than 10 names, but are completely different. The way that you treat it is related with the attachment of the tumor. It's the most important. It's the tumor. The great majority of them are anterolateral or anterior. See, here is very rare to be posterior, lateral, see, but the great majority of them is more anterolateral to the midbrain. What's the problem here? If you go a small tumor, it's more difficult than big tumor. But the big tumor open for you, make the root for you, make the approach for you. And the other thing that is very important to know, what's the difference between these two tumors here? In the cervical spine, here's the craniocervical junction. Very similar. See, what's the only difference here? Is the anatomy. The anatomy of the cervical spine, we are used to. The anatomy from the craniocervical junction, we are not used to. See, making more difficult the surgery here because you're not worried with the anatomy here. If you know the anatomy of the area, and mainly when you study and go to the cadaver, do the dissection, and learn the technique, you can do this easily, how the other way. And the other thing that is very important in the craniocervical junction, looks very similar, but are completely different. This tumor is coming from the spine to the cranium. There is very nice arachnoid plane. This is coming from the cranium to the spine. There is no clear plane sometimes with the brainstem and with the cranial nerves. What's the difference between them? This here is coming from the cranium, okay? The patient has low cranial nerve deficit. The patient, the tumor invade or encase the vertebral artery. The tumor can have on plaque extension, and the tumor can go inside the foramen of the jugular foramen or the see. This you have more difficult to remove this kind of tumor. This here is the tumor that most commonly we see. The tumor is coming from the spine. That patient that comes to you with severe motor deficit, tetraplegic or tetraplegic, okay? The vertebral artery is displaced, not encased. See, there is the mass effect in the craniocervical junction, and maybe have some extradural extension through the foramens. I like to do lateral position, straight lateral position. It's the way that you can see anatomy, not rotate. I don't like to rotate too much the head. See, you can do straight lateral, and you can see directly in the front of the junction. The muscle dissection is very important, but the most important is to identify the vertebral artery. What's the trick to find the vertebral artery? If you go to do the approach, the transcondylar approach, I do only 2 planes of muscle. I don't do muscle by muscle. But the trick is to find C1, the posterior arch of C1. How you found this? With the finger. You know why? Here is very sharp, very sharp. This border here, superior border of the posterior arch of C1 is very sharp. When you put your finger there, you see a sharp bone. See? If you see this, you know that the vertebral artery is superior to it. Okay? It will be easy to identify the artery, easy to find the plane. You can do the muscle dissection to show the triangle, but the most important is, and other trick, Don't try to identify and isolate the vertebral artery like this. Leave the plexus, the venous plexus that is around it. If you start to bleed this venous plexus, the best way to treat this bleeding is not with Surgicel, with glue, okay, tissue, okay, or AVCL. You put glue there and go inside the plexus and stop the bleeding. See, it's the most important and the easiest way to control the venous bleeding of this area. Let me show you a little bit in the cadaver that we did. The incision is not, when you go to retrosig, the center of the incision is externatory meatus. When you go transcondylar, the center of the incision is the mastoid tip. Okay, you concentrate in the mastoid tip. Identify the great auricular nerve, take the sternocleidomastoid, I put anteriorly. Okay, the only one that go anteriorly is the sternocleidomastoid muscle. So this, detach it anteriorly, splenocaptis. Now the splenocaptis and longissimus captis come together. Okay, take the splenocaptis here. See, you can see the occipital artery is the trick to identify and separate the plane. Okay, take only the splenocaptis, is the longissimus captis. Between them there is the occipital artery. Sometimes down, sometimes up. Okay, longissimus captis. Now will be the triangle here. Always there is amount of fat. Some fat here between the, oh, sorry, back. Put wrong one. Okay, one more. Okay. You see, it's difficult to identify the muscle, but there is fat here you found. They are attached on the transverse process of C1. The finger you found the transverse process of C1, you know whereas the triangle. Okay? This is the inferior obliques. There's superior oblique lateral, inferior oblique medial. You found C1, you see very sharp, see? Very sharp. What do? I isolate the vertebral artery here. You open the posterior arch of C1. You open the foramen transversarium and rotate the vertebral artery medially. See? This will expose totally the condyle and expose this posterior part here. Okay, I kept this for the anatomy to show that I have to insert later this. Okay, here's the joint. How much the removal? Minimum or maximum that you need. Okay, don't need to remove too much. Do a posterior fossa craniotomy and leave this border here, and later you remove the condyle. The limit, the lateral limit is the sigmoid size. It will be like a retrosig. Okay, it's an extent of the retrosig approach. Now I have the condyle here. You first drill inside and drill to have the plane here. You see the jugular bulb here? Superior part here. You go, your lateral limit will be the jugular bulb to see directly there. I show a case like this. You can do lateral, a little bit lateral, not too much. See, but it's pinoclival. There is a very nice plane. See. This case like this, totally anterior. But what's the difference here? Look at this. The angle of the lateral mass of C1 and the condyle are open. If the angle is open, see, it means you have more space. If you have more space, you don't need to remove any part of condyle intact. See, the tumor make the approach for you, and the anatomy make the approach for you. And you can see lateral is anterior part. Another case like this, anterior, but the anatomy is not help us. In this case, we need to go lateral, expose. I always liberate the vertebra first. Okay, I go always in the attachment of the tumor. You find the attachment of the tumor. Here, you see one. Sorry, is there 12? Okay, the vertebral artery is totally free, totally liberated from external to internal. Go to attachment there. See, it's here in the anterior border of the craniocephaly junction. Okay, we are going directly to the attachment. You can decompress, make it smaller, but it was not a big tumor. You could, in the plane was very nice with the brainstem. You could cut this and make like a deliver the baby. Okay, the tumor will come out like this. Come. It's small tumor. Okay. When it is larger, you have to decompress. The safest way is to decompress first, to don't play anything. And the vertebral artery, contralateral vertebral artery, the 12 is here. Okay. You play a lot with the 12 in the vertebral artery here. Okay. And in the end, you have all the vertebral artery live free. From C2 to the joint, the 12 here. You are coming under the nerve. If you go through the posterior fossa, through the rectal C, you will work between the nerves. Have to work under the nerves, okay? This is a little bit more difficult case. You know why? Reop. Reoperation is the worst operation that can get. You see, this patient was operated 5 years ago. Previous surgery came to us with this large tumor here. In this case, it was completely different. There was invasion of the adventitia of the artery. You see, we prefer to leave this small sleeve of tumor around the artery than to do another thing. In the artery, well, the patency was permanent, was preserved. Sorry. Okay. And you can do this, you remove the tumor here, you find the vertebral artery from C2 to the craniocephaly junction. Up here, liberate totally the artery. It's very important to liberate the artery. If you don't liberate the artery, the tumor will be stuck on there, will be difficult to remove. And the pre and the post-op preservation of the and the preservation of the function of the vertebral artery. There are cases like this, big one that's come from here to here. What's the most difficult part here? This here. There is no space. Just go inside here, this anterior part, follow it down. See, you go lateral. There, contralateral 12. Hypoglossal of the other side. Okay? Vertebral, 6 nerves there, 6. Okay, lower cranial nerves here, 11th. You are coming from below. You're not working through the nerves. You are coming from below. See, this you can remove the tumor medially. And pre and post-op, the patient. There are cases like this that I showed yesterday. Diplopia, 2 tumors. One petroclival, another one foramen magnum. But in this case, it was very interesting because there was invasion of the jugular foramen. If there is invasion of the jugular foramen by meningioma, if there is no plane, I prefer to leave a small piece of tumor here, okay? Because in my hand, if I try to remove this tumor intradurally, see, I will have problem, the patient have a new deficit. New deficit is the worst thing that it can happen for the lower cranial nerves. If the patient had in the pre-op deficit, okay, you can take the tumor. But if there is no deficit, we prefer to leave. Like this one, see? There was no deficit. I prefer to go there and leave you a small piece of tumor in the jugular foramen here. See? It was difficult to take this part here, it was between the nerves here. Like here, see? If you leave this, you are safe. If this tumor start to grow and the patient has no deficit, I send to radial surgery. If the patient, if the tumor start to grow, and if the patient start with the deficit, we can go there and remove the tumor more. Case like this, one of the worst complications that you can get is like this. Bilateral 12. Bilateral. The patient had in the pre-op homolateral, in the post-op had bilateral 12. See, very difficult in long time. After 1 month, she started to recover the contralateral side. It could start to swallow and how to feed. Neurofibromatosis, benign tumor here, bilateral, large tumor like this. You can go and do it. It's easier, much easier than a meningioma. Another one, come up and down. Just follow the tumor. It's a schwannoma, neurofibroma. Decompress and follow it. You can do, I also have a nice plan. Crazy tumor like this, neuroenteric cyst. See, you can do the surgery also. The problem here is the meningitis in the post-op, more than this. Let's go faster here. See like this. But it's attached to the nerves. Yeah, it's attached to the vessels here. You have to go piece by piece. When you go piece by piece, then the risk of meningitis in this kind of tumor. Okay? You can take this, the pre and post-op preservation of the function. And the last one, the most difficult one, is the intramedullary ependymoma that comes, see, from this area to C3, C4. You can follow, do myelotomy, go inside the medulla and try to remove the lesion. Here, the intraoperative monitoring is essential. It's crucial in this kind of thing. And after, I always close the PIA. Try to close the PIA. If you need to come back, not have adherence. It's very important to close the PIA, you see? The pre and post-op. Okay? Thank you very much. And thank you for the participation. I'll go home.
Oh, okay. Well, excellent presentation. He uses the audiovisual aids.
Finish.
What do you think, Simon?
Yeah, fantastic. That was excellent.
Yeah, the way he puts those slides together, and technically, great presentation. Well, hopefully we can talk to some people. I don't know if we can or not. Ipe, if you're listening, we'd like to talk to you, Albert, or frequently we kind of, that's the problem with not having. Oh, okay.
Ipe's in the chat.
Oh, good. I see. Yeah, I'm good. Ipe. There we go. Yeah, okay. Yeah. Okay. Okay, it's time to fill the air with neuroeducational material content, Simon. So I'll let you take over.
Where do we start? Amazing. You have a great deal.
Yeah, Lewis is, wow, he could teach a lot of neurosurgical residents and neurosurgical lovers throughout the world. And that's the way this, I was just, chatting with Salman Sharif. He's a back surgeon from Pakistan, but pretty well known.
Mm-hmm.
And I just mentioned to him, because Victor is doing a lot of work on the spine. I guess one area of neuroanatomy that's kind of neglected, it's like a poor sister, is a spine, because most anatomists pay attention to the brain itself, but not too much to the spine. I think Victor's doing some kind of book on the spine, neuroanatomy of the spine. What she feels is a neglected part of neuroanatomy.
Yeah. Great. Hope to see some more of that.
Yeah.
2 new channels coming soon. That's great.
I hope so. I hope Albert likes the tech and sees the
You're
videos.
the Ted Turner of neurosurgery.
What's that?
You're the Ted Turner of neurosurgery.
There we go. There we go. I was thinking about that today. Ted Turner was a pioneer in television because he used to travel to Newport. You remember he used to race in the American Cup? He was also a great sailor.
Right.
And I think he actually won the Cup.
He did.
And he traveled to Newport way back in the beginning of cable TV. And he would bring his own tower.
Really?
To these, to Newport, which is a very chi-chi. He would bring the tower and put it in the yard of where he was staying.
The broadcast.
People thought he was crazy, but he wanted to see the Atlanta Braves, his team. So he brought the tower. He really pushed the tech of cable and said, "Hey, this can be done." And he was one of the big pioneers of cable. That's why cable. Everyone has cable now, but he started it. He was one of the big proponents. It was there, and he really pushed the tech. He was at my brother's house. He's a Brown alumni.
Yeah.
But it's a little known fact that he was thrown out of Brown. But of course, that's not mentioned too much. Just that he attended Brown because they want to get his contributions.
What's interesting to me is how the presenters are wearing scrubs.
Yeah, well, I guess they had the morning didactic lectures, and then they had the lab, and they come right from the lab. They just go one from one to the other. But yeah, everyone wears. I don't see why there's aseptic technique is used. Why they have to use masks? I don't know if they wear masks. You don't want the cadaver to catch an infection. What do you think, ¿Qué piensas, Marco?
Marco's here.
Yeah, he's been in all the sessions.
Yeah.
Hi, Marco.
Yeah.
Marco, you've been in all the sessions.
Enjoying?
Yeah. Oh, amazing. I really like those videos and the cases. Very difficult cases also. That's amazing.
Yeah. I'll. They're all recorded, and of course, it'll be edited. But, dog, if I stop this broadcast, that means I can't start another one. You know what I mean? So I gotta just keep on. But we might get lucky. I doubt if. See, Albert is there on the stage. I would love to talk to him. Love to interview him if he. And I know. Maybe I'll write to. Like he's just sitting there. We'd love to interview him. Let me. I'm gonna write. I wrote to. I'd like to interview him. Let me write to Anna. Okay. Let me email. I think he expects to be interviewed.
We really need someone on the floor, don't we, with a mic?
No, I don't know if they can. see us. You know what I mean? I think this just may be, I think the way you had it set up, it's a dedicated video feed. That's all it is. He doesn't have it hooked up through a Hangout, I don't think.
Right.
It's just a video feed. It's like a camera. And there's no, he can't see us, but I did talk to her once, and she could hear me. She responded to my questions, Anna, when we were setting up.
It's part of the live broadcasting. Yeah, it's just connected to the camera, I believe. That's it.
Yeah, that's it. So I really doubt that we'll be able to talk to anybody. Well, but anyways, there's a money shot. We get to see the schmoozing around. There's Lewis. Of course, if I was there, I'd be bending his ear. I don't know who the other gentleman on the stage is. I think that could be the Dolan, Dr. Dolan. He's the, look, someone's taking a picture, Lewis. This is one of the, I think he's a Serbian, from Slovenia. Yeah, I just wrote her an email saying, I'd like to interview you. Now, I think these are mostly neurosurgical residents from Russia. Because whenever there's a break, that Albert speaks Russian.
This is the final day.
Yep. Yep, the party's over. I don't know if you've seen on Ipe's Facebook page, but there's apparently like a castle that he brought a bunch of them to dinner.
Really?
It's a wooden castle, yeah, and you know, there's a lot of snow, not a lot, but there's a good bit of snow on the ground there now. But you see where it's located, southern Siberia, at the edge of, I don't know if it's India or some other countries.
The coldest summer I ever spent was the winter I spent in Siberia.
Siberia, yeah. They don't have probably a long summer. Okay, they just booted us off. We lost the telecast. So I'll stop it here.